Welcome to the second instalment of the Independent Hospital Pricing Authority's education webinar series. We're going to be talking about our work on safety and quality reform. My name is Samuel Webster. I'm the Director of Pricing at IHPA.
And I'm Chereta, Director of Policy Development at IHPA.
So a brief outline of what we'll be going through. We'll give a bit of introduction of IHPA, some background of safety and quality work that we're doing, in particular go into a bit more detail on our work on Sentinel events, hospital-acquired complications, avoidable hospital readmissions, and how to identify them, how the funding and price adjustments work, and discuss a couple of case studies. We'll then go on and talk about the impact and relevance to hospital pricing and funding, and then discuss some of the future directions of work. After this webinar, there'll be an opportunity for a live Q&A involving the Australian Commission on Safety and Quality on Healthcare, and we'll give you those details at the end of the talk. The Independent Hospital Pricing Authority is, as the name suggests, independent of all governments. So we're governed by a 9-member board, which is elected by states, territories, and the Commonwealth. We were established under the National Health Reform Act in 2011 as facilitating the national implementation of activity-based funding for public hospital services. We have a very strong consultation and transparency agenda. Everything that we'll discuss in this talk today is available in publications on our website, and all decisions we make to come to these decisions discussed in detail throughout a whole series of committee meetings and working groups involving various stakeholders from technical experts, clinicians, and policy advisors. Our key function is to determine the national efficient price annually, which goes on to impact the public hospital funding calculations. So public hospital funding in Australia, so as we know, we are a Commonwealth of states and territories. So there are 8 states and territories, and each state and territory considered service managers for their public hospital services. And the funding for those public hospital services is determined in part by the state and in part by the Commonwealth. So the Commonwealth contribution to public hospital funding is based on the change in price for a given service and also the change in volume of those services. So states and territories determine the volume and distribution of those services, where the Independent Hospital Pricing Authority determines the national efficient price each year. And those two pieces of information go together, and the National Health Funding Body calculates the Commonwealth contribution to public hospital funding in Australia. So IHPA's functions broadly are, as I mentioned, to set the national efficient price. So we canvass the inclusion of safety and quality measures from our inception in 2011. We also develop classification systems for public hospital services, coding standards, and national data standards as well. So nationally consistent costing standards, and data collection standards. So in 2016, the Council of Australian Governments met and agreed, so all jurisdictions, premiers, and the Prime Minister agreed to take action to improve the quality of care in hospitals and reduce the number of avoidable hospital admissions through a number of mechanisms. So specifically, improving hospital pricing mechanisms to reflect safety and quality of hospital services by reducing funding for unnecessary and unsafe care. And there was particular direction around reducing hospital-acquired complications at the time, and also scope for pricing for avoidable hospital readmissions.
So further to that, in 2017, through the addendum to the National Health Reform Agreement, parties committed to improve Australian health outcomes and decrease avoidable demand for public hospitals through a number of health reforms. And these include the development and implementation of funding and pricing approaches for safety and quality. These reforms are designed to improve patient outcomes in the public hospital system. The commitment by Australian governments to safety and quality followed a 4-year program of work. So it was a collaborative work between IHPA and the Australian Commission on Safety and Quality in Healthcare. And that was to incorporate safety and quality measures into the National Efficient Price Determination. IHPA specifically was required to advise on an option or options for a comprehensive and risk-adjusted model to determine how funding and pricing could improve patient outcomes across 3 specific areas. And so these were sentinel events, hospital-acquired complications, and avoidable hospital readmissions. Further to this, in the addendum in 2020, the new addendum to the National Health Reform Agreement 2020-25, again, further cemented IHPA's role in progressing with these safety and quality reforms, and including pricing and funding for public hospital services to improve patient outcomes. And I guess that's where IHPA has further progressed its work in progressing with a funding approach for avoidable hospital readmissions. So in summary, obviously, we have to date implemented an approach for sentinel events, which includes 0 funding for sentinel events. That was introduced back on the 1st of July 2017. We have an approach which is reduced funding for episodes with a hospital-acquired complication. IHPA applied that approach from 1 July 2018. And again, a reduced funding for avoidable hospital readmissions, and that approach has applied from 1 July 2021.
So in developing these approaches, part of the literature review and research that ourselves and the Commission had done showed that there's a fairly universal statistic that in Australian and international studies that estimate that adverse events such as these explain between 12 and 16.5% of the total cost of care in the hospital setting. So obviously, not only do these adverse events have detrimental effects on patient care and patient experience, but they also have a fairly serious financial impact by increasing the cost of care. So we've undertaken a fairly significant piece of work over a number of years to incorporate these measures into our pricing of hospital services. And this is part of a bigger scheme which involves educational programs, safety and quality standards and certification to improve safety and quality in the public hospital setting Australia-wide. At IHPA, we're focused on the pricing side of it, but the Commission has developed a lot of those other materials that I mentioned. So in order to do this, we currently collect a lot of cost and activity data for public hospital services. So specifically, the activity data is a very rich data source. So the ICD-10-AM classification, that's the International Classification of Diseases, the Australian modification, is a very rich source of safety and quality data, and up until recently, fairly underutilized. And this allows us to identify where these adverse events may occur. A literature review showed that there is very good evidence that the provision of timely clinical information to clinicians and managers does lead to improvement in patient outcomes. And lastly, the pricing signal provides a clear sign that government values safety and quality on one hand, and on the other hand, it promotes discussion of safety and quality system amongst clinicians and managers. And we've seen this firsthand filter down after setting these prices into the hospital setting, where a lot of hospitals and managers, etc. There's been a lot of focus on hospital-acquired complications in the past couple of years, and readmissions more recently. So the adjustments that we make recognise that pricing and funding approaches, there needs to be a balance. So balancing the likelihood that some patients will be at much higher risk of experiencing an adverse event, while at the same time recognising that all hospitals have some scope to improve safety and quality. So we'll now talk about through the three programs we've been looking at. So the Sentinel events, the hospital-acquired complications, and avoidable hospital readmissions. So first is Sentinel events.
Thanks, Sam. So Sentinel events, are defined as a subset of adverse patient safety events that are wholly preventable and result in serious harm to or death of a patient. They're the most serious incidents reported through each of the states and territories' incident reporting systems. Just on the screen now is a list of the current Australian Sentinel events list that obviously result, if these items are reported, then they result in zero funding. So the Sentinel events list was first established back in 2002. In April 2004, Australian health ministers determined that public hospitals should report on Sentinel events, and that was at a national level. Since 2007, the Sentinel events have been reported by states and territories, and that data was shown through the Productivity Commission's report on government services report. Since 2017, the Australian Commission on Safety and Quality in Healthcare undertook a review of the Sentinel events list on behalf of states and territories and the Commonwealth, and the updated list was endorsed by health ministers back in December 2018. So the Commission now currently manage the list and all the associated criteria. The list itself, is reviewed by the Commission. They have an expert group that oversees, queries concerning the classification of Sentinel events, and the group consists of clinical, policy, and operational experts. And again, for more information, there is a lot of stuff on the Commission's website, and the latest version of the list will always be available on that website. So as mentioned before, the funding approach for Sentinel events is that no funding will be provided if an episode of care includes a Sentinel event, as per the Sentinel events list, and obviously resulting in zero funding for these episodes. And just to take it a little bit further, we've, as Sam mentioned earlier, we'll include a case study for each of these. So an example here is a 47-year-old male was admitted following a motor vehicle accident and presented with severe respiratory distress requiring airway support. Airway intervention was administered by the attending physician. 10 minutes following this procedure, it was discovered that the artificial airway was administered in the wrong location, in the esophagus. The patient suffered a cardiac arrest, resulting in death. And as the patient died due to an invasive procedure being performed on the wrong site, the hospital received zero funding for this episode of care.
Right, and hospital-acquired complications. I think you've got this one as well, Chereta.
Thanks, Sam. So hospital-acquired complications are defined as complications which occur during a hospital stay and for which clinical risk mitigation strategies may reduce but not necessarily eliminate the risk of that complication occurring. Again, on your screen, you can see the current list of hospital-acquired complications. The list itself, obviously, all identified on the basis of ICD diagnosis and procedure codes. So there is quite a significant list of subcategories under each of these categories here. List itself was developed with IHPA and obviously in consultation with the Commission. IHPA's role in developing the hospital-acquired complications list is to implement national activity-based funding for Australian public hospitals. And the Commission's role, obviously, in that was to lead and coordinate national improvements in safety and quality in healthcare. So the Commission and IHPA established a joint working party, JWP, and they were formed to, I guess, review and come up with a list of hacks. So I guess that the final result was that the list of conditions for which clinical risk mitigation strategies may reduce the risk of their occurrence. The key criteria in developing the list was obviously preventability, the impact on the patient, the service impact, and again, clinical priority. As with the Sentinel events list, so the Commission is responsible for the ongoing curation of the hospital-acquired complications list. And the HACS list is reviewed regularly by the Commission's HACS Curation Clinical Advisory Committee. So they meet on a regular basis and are regularly reviewing the list and the criteria associated with that.
Alrighty, so on to the how these hospital-acquired complications go on to impact pricing and funding, and specifically how we account for risk. So we do recognise that all HACs across every hospital, under the direction was that they would have reduced funding to reflect the extra cost of a hospital admission with a complication. So the magnitude of that reduction varies with each complication. And in addition, the patient's complexity is used to risk adjust that reduction. So for example, an older patient with a much higher risk of having a complication would not have as great a reduction as a younger patient with that same complication. So broadly, the funding approach is broken into, or the funding adjustment is broken into 3 steps. So when we calculate this, it's all based on the data that we collect, individually costed patient level data from public hospitals in Australia. And we first calculate the incremental cost of each complication, and that's determined by comparing the cost of an episode containing a HAC to those episodes without a HAC. And that comparison accounts for, different, based on the same kind of patient characteristics. So accounts for changes in case mix or variation in length of stay and other patient factors. We build a risk model to calculate dampening factors. And so these factors, so they're based on the complexity or the risk of a patient having a complication. And then those two are combined. So the incremental cost is combined with a dampening factor depending on the risk of the patient. And that goes on to form the final funding adjustments. We'll see how that works in a minute. So the first step is the incremental cost. So for example, we can see for HAC 8 is renal failure. So here the incremental cost there is 18.9%. This is taken from the 2021-22 determination technical specifications. So saying it has an 18.9% incremental cost means that if a patient episode, all other things equal, will cost 18.9% more if it has the complication. So as an example here, if there was the cost of an episode was $100, and if they've got patients with renal failure, on average would cost around 19% more, so that would mean $119. Now this has to be transformed as part of the pricing model. So the other way to look at it is that an episode without a HAC, so this is, if you have an episode with a HAC, then what's the adjustment to remove the cost of that HAC from that total episode? costs. So here we can see for renal failure, the adopted adjustment here, this table's in our technical specifications, is 15.9%. And what that's saying is that if there's an episode that's identified to have a complication, then say it's the $119, then less 16%, which is the adjustment for having a hack, gets you back to that $100 figure, which was the episode without the complication. So they're just two ways of, one of them is an increase on the incremental cost is the increase on the cost of a patient without the complication, where the adopted adjustment is what decrease is applied if a patient does have that complication. Now this adopted adjustment is actually the maximum possible adjustment that could be applied for a complication, but there is this whole concept of risk behind it as well. So as an example, this chart here shows the incidence of hacks, so the percentage or the rate of complications occurring by age, and each color in each bar here, that's all the different hack groups. So there's 16 different colors. Some of them you can see are much bigger than others. The larger yellow one at the bottom is infections, for example, and we can see that generally for all of the different hospital acquired complications, they tend to increase with age. And so age is a very significant driver here. So as an example for a specific hack, here we have, this is based on 2 years of admitted acute data, and showing the percentage of patients by age which have a fall, which results in fracture or other intracranial injury. So this is hack number 2. And we can see that as age increases here for that hack, the percentage of hacks increase as well. So age isn't the only risk factor though. So if we calculate risk based solely on age and build a risk model out of that, and then try and test it with some other patient characteristics. For example, whether the patient was transferred from another hospital or not. So here we have the bars here show the number of episodes for patients which were transferred and patients which were not transferred. And if we consider only age when determining the risk of having a hack, so this is a dotted line here, it says that they're almost like that. Using an age-only model shows that, or would predict that they're roughly at the same risk of having a complication, whereas the solid line here shows that actually transfer patients, there are a much higher rate of complications for transfers. And so there are other risk factors that we need to consider. So the first model that we made was based on age only. We undertook significant amount of consultation with our clinical groups and with universities. Specifically, we worked with the University of Melbourne to develop our complexity model, who provided a lot of advice. Throughout our consultation, we considered hundreds and hundreds of risk factors. About 80 of them we were able to identify and test in our data. And from that, we went through a systematic process of identifying which were the most influential and significant risk factors to incorporate into the model. So we then built a separate risk model for each individual complication. So this table here, you'll also see in our technical specifications, which shows that the various risk factors that we consider, like emergency admission status, patient age, major diagnostic category, intensive care unit status, whether the diagnosis related group that the patient is classified into is an intervention or other, Charlson comorbidity score. So there's a number of risk factors here, and some of them apply to all complications and some of them only apply to a subset of the hospital acquired complications. So after building this risk model, we're able to use it to determine the dampening factors for each complication, which results in the table, final adjustment table you see in the National Efficient Price Determination. So this is from the National Efficient Price 2021-22. And we can see there is some, so we've got our complexity groups defined based on their risk. So we've got high, moderate, and low complexity groups. Again, we considered many different options here about having just a risk score, or 5 groups or 10 groups, and it worked out that 3 groups seemed to work best with the data that we had to explain the risk, but also make it fairly easy to understand. So there is some variation here. So you can see HAC2 for falls, the low complexity group will receive a 3.7% adjustment to the price when that's calculated. Where if you're in moderate or high complexity, that's a much smaller adjustment. It does range a little bit. So renal failure, fairly serious complication if it occurs within hospital, gets a 16% adjustment. But then as the complexity of, or the risk of receiving that, or the risk of that complication occurring increases, that reduction, that adjustment reduces significantly. So to go through a case study as an example, so a 27-year-old female patient was a booked admission to day surgery for a cholecystectomy. She had no comorbidities. Following her surgery, she fell off the bed in the ward, hit her head on the floor, and a computed tomography scan showed a subdural hematoma. So that patient remained in hospital for further treatment and surgery. So as that patient acquired a fall resulting in intracranial injury in the course of her hospital stay, that episode of care would potentially be subject to a HAC adjustment. So we published all the different risk scores in the technical specifications. So here are the scores pulled from those technical specifications, and there's a baseline point score, and they all get added up. So age group 25 to 29, Charlson score of 0, it was an intervention diagnosis related group, etc. And they all add up for a total point score of 30, which places that particular episode in the low complexity group, which has a maximum of adjustment of 3.8%. And because they're in low complexity group, that's not dampened at all. And so that final adjustment to the price that's calculated for the Commonwealth contribution to hospital funding would be a 3.8% reduction in the price. Right, onto avoidable hospital readmissions. Chereta.
Thanks, Sam. So our last area of safety and quality reforms at the moment is the avoidable hospital readmissions. So an avoidable hospital readmission occurs when a patient who has been discharged from hospital, that we call the index admission, is admitted again within a certain time interval, referred to as the readmission. The readmission has to be clinically related to the index admission and has the potential to be avoided through improved clinical management and or appropriate discharge planning in the index admission. So each readmission category includes several subcategories. So again, on the screen, you have a list of the current readmissions list. And each subcategory includes a time window or a readmission, an interval window for that specific readmission category. Again, as with our other lists, the Australian Commission Safety and Quality in Healthcare developed the list of conditions. And so these were originally based on the hospital-acquired complications list. The list was established based on the list of HACs, but also informed by literature review on avoidable hospital readmissions, and obviously our public hospital data undertaken through analysis of our admitted patient data. The list obviously was also developed in consultation with clinical and consumer experts, and obviously our involvement from IHPA in that process.
Alrighty, so we'll touch on the adjustments for avoidable hospital readmissions as well. So we can see here a similar chart to the one we saw for the hospital-acquired complications. This is by readmission, the different readmission categories from 1 to 12 here. And we can see similarly that the rate of readmission increases with age. So this is the readmission percentages of total population on the left and age group on the right. And so that it doesn't, some readmission categories increase more than others. So for example, you can see the one at the top here, which increases a lot with age, I think is cardiac complications, whereas some of the others don't necessarily increase with age quite as much. But this kind of goes to show that obviously risk adjustment is going to be a key part of this as well. So the overall funding approach is similar to that of hospital-acquired complications. So where with hospital-acquired complications, we calculated that maximum adjustment or incremental cost, and then applied, risk adjustment or a risk model to that to obtain the final adjustments. Here, it's a little bit different. So where hospital-acquired complications, it was fairly clear to be able to compare what the additional cost of having that exact complication would be for a given episode of care. For readmissions, so the adjustment on the index episode is based on the price of the readmission in this case. So where there's an index episode and a subsequent readmission, it's based on the price or the cost of that readmission episode is the basis for the adjustment, and then and that's used as a basis for reducing the price of the index episode itself. So noting that the readmission episode is still fully priced, it's only the index episode that receives an adjustment. We undertook a similar analysis of risk factors. So the avoidable hospital readmissions are, there's generally a lot less of them. They're much sparser in the data, which makes constructing a robust risk model a little more challenging, but we were able to do so. And as the resulting risk model published in the determination, so this table, again, taken from the latest NEP determination, looks slightly different for the equivalent table for hospital-acquired complications. But here, this is the dampening factor that's applied to that, the price of the readmission episode, and then deducted from the index. And so here we can see for low risk index episodes, the full price of the readmission is deducted from the index, whereas the complexity of those index episodes increases. So high complexity, there's only a portion of that readmission price that gets reduced, deducted from the index. So another case study for avoidable hospital readmissions. So a 54-year-old female patient underwent an emergency appendectomy following a diagnosis of appendicitis. She was otherwise fit and healthy with no comorbidities. 7 days after this patient was discharged, she presented at the emergency department at the same hospital as she was experiencing acute pain in her lower right abdomen. As a result, she was readmitted. As this meets the definition of avoidable hospital readmission, there will be a impact on the Commonwealth contribution to funding for that hospital. So a price adjustment is applied to the index episode, which is based on the total price of the readmission episode. As the patient was considered low complexity, the price for the index episode is reduced by the total price of the readmission episode. So now I'll talk a little bit about how these adjustments actually apply to funding. So as I mentioned earlier, IHPA's role is to set the national efficient price, which is used to calculate the Commonwealth contribution to public hospital funding. And I think it's a really important point here to stress that the funding of public hospital services is shared by the Commonwealth and the state. And so there are different state funding models that apply these various adjustments to different degrees. They don't necessarily follow exactly what the national models do. So this only applies to the Commonwealth contribution to that funding. So as just a recap, as we mentioned earlier, the Sentinel events receive a price of 0 in these calculations, where hospital-acquired complications and avoidable hospital readmissions both receive a price reduction. So Commonwealth funding is based on the growth in efficient price. And so that's calculated as activity times price. So if you look in the National Health Funding Body, public hospital funding policies, or in the IHPA National Efficient Price Determination, it gives the exact formula for the efficient price of any given hospital service. Activity is generally measured in National Weighted Activity Units, or NWAU. We've kind of avoided discussing NWAU in this presentation. All the detail is probably, another whole presentation in itself. But it's essentially a measure of episode resource use relative to the average cost of an admitted episode of care. We'll go through these examples using dollar equivalents, but I thought I'd just note that. So this is a fairly simple example, just made up data of the Commonwealth Growth Funding contribution for between 2 years. So here we have, this has no safety and quality adjustments at all. So in 2018-19 for a particular hospital that might have a total efficient price of $1 million. In the following year for 2019-20, their efficient price is $1,050,000. So this is a growth in efficient price of $50,000. And therefore the Commonwealth growth funding associated with that is at a rate of 45%, is $22,500. So including safety and quality adjustments, so this is where there are Sentinel events, they get 0 for their efficient price or reduced amount for complications and readmissions. So in this example, they're fairly stable in terms of the numbers of Sentinel events and other adverse events. And so there's a $20,000 total deduction in 2018-19 and 2019-20. So then when we look at the efficient price with this safety and quality deduction as well, we see then the first year it's a total efficient price of $980,000. In the second year, the total efficient price is $1,030,000, and the growth here is still $50,000, and the Commonwealth growth funding, 45% of that is still $22,500. And I think the key message here is that because of the way that Commonwealth public hospital funding works, if those rates stay fairly consistent, there's not actually a significant impact at all on the Commonwealth contribution to funding. Where it does come into effect is if there's an increase in rates. So if there's a large increase in the number of hospital-acquired complications and readmissions from one year to the next, then that will result in a reduction in Commonwealth growth funding. On the other hand, if there's a significant decrease in complications and adverse events, that will actually increase the Commonwealth growth funding. I'll pass it to Chereta now to talk through some of our future work plans.
Thanks, Sam. So just to talk a little bit about what next. Obviously, as we've mentioned, we on an annual basis are constantly reviewing our approach to sentinel events, hospital-acquired complications, and avoidable hospital readmissions. So we work quite closely, obviously, with the Commission in reviewing the lists and the criteria and whatnot. So that work is obviously always ongoing. In the same space, under the addendum to National Health Reform Agreement, we're also have been asked to look into avoidable and preventable hospitalisations. So again, working quite closely with the Commission and the National Health Funding Body to progress some work in that space. So developing an approach for addressing preventable hospitalizations. As you know, as we've talked about, the Sentinel events and HACS approach have been in place for a number of years now. We've just had readmissions starting 1st of July this year, but we're in the process of also developing a safety and quality evaluation framework. And again, this is in line with the Commission to set up a framework and understand you know, how the adjustments have been working, and being able to use establish a framework for us to be able to do that. So we're currently in the process of developing that again as a requirement under the addendum, but we'll be working with states and territories quite closely in developing that to ensure that, you know, it covers and assesses and evaluates, you know, all aspects of our safety and quality reforms. And the last one, I know in our recent pricing framework consultation papers, we've talked about looking at some avoidable hospital readmissions software tools, and this is, I guess, you know, some commercial readmission software, which again will hopefully assist with reviewing the list of readmissions, again using our rich data set to review the list and see whether it's possible that we can expand the readmissions list. Again, this will be a quite significant piece of work and something that we will do in consultation with the Commission and see our key stakeholders. You know, and I've mentioned a number of times now, but you know, we'll also have ongoing consultations with the Commission in reviewing all aspects of our safety and quality reforms. And our last, I guess, last couple of slides is, as Sam mentioned at the beginning, we will have a live Q&A. It will be held on Wednesday, the 18th of August at 12 p.m. Australian Eastern Standard Time. You know, and a great opportunity to ask questions on, you know, pricing and funding of safety and quality. You know, if you ever have any burning questions to ask, that's the opportunity to do it. There will be obviously IHPA executives available, and as Sam mentioned before, we'll have some representatives from the Commission too that will be available to ask any questions. So please register and show your interest and come along to that. But as always, thank you for your time. If you have any questions, please feel free to get in touch.
Thank you.
Thank you.
Our website, I mentioned a lot of that material is available, and also our socials. Thank you.